Worldwide, heart failure morbidity, mortality, and the costs associated with treating heart failure are just humongous. And in the April 2nd issue of JACC, there is a paper we're talking about on the incremental cost effectiveness of guideline-directed medical therapies for heart failure. And I am with Gregg Fonarow, MD, Director of the Ahmanson UCLA Cardiomyopathy Center and Associate Chief of the UCLA Division of Cardiology. First, what was the genesis of this paper that's in JACC?
So this was a study to look at the value offered by standard guideline-recommended heart failure medications, where there had been prior cost-effectiveness analyses that had looked at individual medications, and at a time where they were branded medications and more expensive. There had really not been any analyses looking at the cost-effectiveness now that these therapies have become generic, and importantly, had not looked at the incremental value offered by these therapies when used in combination. So we were very interested to see what type of value these therapies, when used in clinical practice, offer patients with heart failure.
So how did you do the study?
So we used existing data from clinical trials to estimate the cost and utilization of resources in patients with mild to moderate heart failure, as well as the efficacy of these therapies individually and in aggregation, and looked at then using standard type of analytic approaches, the Markov model, to look at what the cost per quality adjusted year life saved were each of the major classes of heart failure medications, ACE inhibitors or ARBs, beta blockers, and aldosterone antagonists. And so looked at individually as well as incrementally the value of each of these medications.
And what did you find?
So what we found was actually very impressive, that these medications were not only cost effective, that generally means a cost per quality adjusted year of life saved of less than $50,000, but they were actually what we call cost dominant or cost savings, that applying the medications extended survival while at the same time lowering cost of care, mainly driven by a reduction in heart failure hospitalizations in these patients. Importantly, beyond the benefits of ACE inhibitors or ARB therapy, the addition of beta blockers remained cost dominant, that you were extending survival even further, but at reduced total cost compared to the base case of just diuretics alone. And likewise, the addition of aldosterone antagonists also was at exceptionally good value. So you extended survival to the greatest degree with all three classes of medications applied to these patients, and did so at very impressive either cost effectiveness ratio or one where you're actually providing better outcomes at lower costs, saving the health system, or from a health provider's perspective, money.
So these were, again, low to moderate heart failure patients, and these were also people who were, in theory, on optimal therapy because they were in major clinical studies. Is that correct?
Well, in fact, we used some of the original trials looking at therapy where it wasn't what we would consider optimal by today's standard. But that's the only way to do the analysis, to look at the incremental benefits. So the base case were patients just treated with diuretics plus placebo, but then the addition of ACE inhibitors that lowered mortality and the rates of hospitalization. And from an economic standpoint, were able to extend life while at the same time saving money. And then looked at the incremental value of the addition of beta blockers, and then the incremental value of to an ACE inhibitor and beta blocker, the incremental benefits of adding an aldosterone antagonist. So we tend to think of the therapies we add for patients with heart failure that the underlying disease is an expensive condition, the therapies are expensive. But here we find the case where we're improving outcome to such a degree we're extending survival in these patients, but actually lowering total cost of care. So that's something that's very rare in cardiovascular medicine, much less a disease state like heart failure. And that these medications, now that they've become generically available and low cost, are actually offering tremendous value. And because of that, with the focus on cost of care and providing therapies that provide good value, it means we really need to be investing further to ensure all eligible patients with heart failure who qualify for these medications are actually receiving them in clinical practice.
So things like Get With the Guidelines, it's a good investment of your organization to put some money into getting more people treated to guidelines for heart failure, mild to moderate.
So absolutely, quality improvement programs like Get With the Guidelines, like the NCDR Pinnacle Registry that are focused on ensuring eligible heart failure patients are treated with each of the guideline-directed medical therapy. This study tells us not only are we improving the outcome for patients, we're doing it with exceptionally good value with these medications. And in fact, we even estimated you could spend up to $15,000, $16,000 on your disease management program to ensure that patients were treated with each of these medications and still stay within that realm of being highly, highly cost effective of less than $25,000 per quality adjusted year of life saved.
So this is a paper that is coming in JACC. It is the April 2nd issue of JACC, and it's Incremental Cost Effectiveness of Guideline-Directed Medical Therapies for Heart Failure. Make sure you go to CardioSource World News, where you'll also read more JACC summaries in our JACC in a Flash section. For CardioSource World News, I'm Rick McGuire.